all, and welcome and thank you for joining us today. We're going to be thinking about CQC's new regulatory model during the course of the next hour. My name is Victoria Vallance and I am a Deputy Chief Inspector here at the Care Quality Commission, and I'll be taking us through our next hour. But if we could move on to the next slide, I'd like to let you know who else is here from the CQC team. So I'm joined today by a number of colleagues. I'd like to start with a thanks to them, and I'll be bringing them in no doubt later on to support with queries and questions in our discussion. But we're joined by Fiona Allinson, one of my colleagues as a Deputy Chief Inspector in the Hospitals Directorate, Claire Land, our Head of Acute Policy, Becky Appleby-Dean, our Senior Provider Engagement Officer, Abigail Walker from our Communications and Engagement team, and Steph Lowe, our Excellent Events Officer. So those are the colleagues in the background, and hopefully you will meet them through the course of the morning. Just a few housekeeping-esque points before we set off, if that's all right. So we're really hoping that you find this time useful and productive. We're not anticipating any technology faux pas, but please bear with us. These things do happen, so we'll resolve anything as quickly as we can if we do face any challenges. We'll be doing our best to stick to time. And the way this webinar is set up, only the webinar member, so that's myself at the moment, will be able to speak. So it's kind of one at a time on screen. So that's to accommodate the numbers of colleagues that we're expecting to attend the call, if that's okay. But please do use the chat function. Hopefully you're all familiar with chat facilities. It should be to the side of the screen. Please do ask any questions, any comments, and we will be turning to those as we reach the time for discussion after the slides. For your information, this webinar will be recorded, uploaded to our YouTube channel, and lastly, the slides will be sent to you after the event, so no need to frantically take notes. We will be sharing the recording with all. Okay, off we go. So the running order for the morning is to talk to a recap around CQC's strategy, some of our ambitions. We'll be thinking then in more detail around our current hospitals regulatory approach and inspection priorities. And then we'll move on to thinking, so what does that mean in terms of the current model and our ambitions then for the future regulatory model. We'll talk to you then around some of our plans for our single assessment framework. And finally, as I say, and I'm really keen to get to this part where we can open up for discussion, hear your comments, take any queries and questions that you have. So I hope that sounds okay. Plan for the next 55 minutes there. So without further ado, if we can move on. So our strategy. We are, and we hope to continue to be, extremely ambitious. That means we are changing the way that we regulate. It's all about our role to improve care and services for everyone. We want to be more relevant to the way that care is delivered, and indeed we want to be more flexible. We want to manage risk and uncertainty in a more mature way, and we want to be able to respond quicker, more proportionately, and importantly to all of you, I know this last one, we want to keep our ratings up to date. That said, our primary purpose and our role isn't changing at all. It's all in how we achieve it that needs to change, and indeed will change. Through our strategy, we set an ambition to develop an approach to regulation that's driven by the needs and experiences of people and communities. We want our approach to be focused on safety cultures, learning, collaboration across the entirety of health and care. And importantly, we want to keep focused on accelerating improvement. We also know that we want to be, need to be smarter in the way that we work, to make better use of data and insight, using the best available methods to gather our evidence and indeed interpret our evidence towards judgments. And this is our new strategic direction as the health and care environment continues to, always will continue to evolve. So that's the big picture seen on the strategy. We can move on, please. Okay, so our current regulatory approach, and you'll all be familiar with some of this, I would imagine. So throughout the pandemic, we've kept our regulatory approach under review. This is in recognition, of course, of the changing pressures that health and social care services have found themselves working under and addressing on a daily basis. Our priority has always been to support services to ensure that people are receiving safe care, and we want to ensure our approach through some of our evolving methods has remained appropriate and indeed proportionate. So in December, we postponed our inspections of some services to support, for example, the acceleration of the vaccination booster programme. And we also prioritised our activities so that we were helping create capacity in adult social care by inspecting, by looking to ratings, quality improvement, therefore playing a role for the capacity in the system. So let's think about our activities since the 1st of February. So we have been inspecting where there is evidence that people are at risk of harm, and that applies to all health and social care services, including those where planned inspections were previously postponed. Where we can support increasing capacity across the system, as I say, we've done that, and that's been primarily through our inspections of adult social care. And equally, we've kept a focus on urgent and emergency care through some of our systems-based activities, understanding the pressures across those local areas and partners working together, where there might be local support, national support needed, and equally it's been around sharing good practice to drive improvement. But what does that mean? Aware of the audience here, so what does that mean in terms of inspection priorities for acute services, first of all? It means that at the moment we're prioritising those services never inspected. So the services where we have the power to rate, particularly where the provider was registered prior to 2019. Equally, we've been undertaking our direct monitoring approaches for services, especially around our independent provider portfolios. And as highlighted, that's around us addressing particularly some of those services that we have not touched or rated since registration prior to 2019. And again, we've restarted the urgent and emergency care programme. That's across the place, thinking to all providers. What does it mean for mental health and community services? It means mental health inspections have continued as planned. Again, inspecting where there are risks identified, including, particularly here, a focus for us where there are any indicators of a closed culture. Again, it's the services that we've never inspected but do have a power to rate. And equally, two additional elements to our work here, we've continued our Mental Health Act review work. So any of those mental health reviews that were planned, all gone ahead. We've continued our second opinion appointed doctors work. And then lastly, we again in this sector have focused some of our attention on direct monitoring. Again, a lot of activity here across our independent providers. Okay, so our next slide. This is all about our model now and what some of the changes might feel like in the future. We know it's really helpful to see how the future can relate to what we've been doing over the last circa 8 years or so, and that's what everybody here I'm sure is familiar with. So some examples of what could feel different. In terms of our assessment framework, at the moment we have 3 different frameworks, and those are for registration, health and adult social care, and they cover the 5 key questions. We're all familiar with those, but they are duplicative across particularly the key lines of inquiry, and they're not wholly relevant as they now need to be to health and care in the world for today. So what will that look like in the future? We'll have a single assessment framework, and that framework will cover all sectors, all services and all levels across, right from providers right through to the system. And this is going to simplify things greatly, not just for us and CQC, importantly for providers, for partners working out in the systems. What we look at won't change through the framework significantly, but how we do it will feel very different. So, for example, our single assessment framework now is built on those 5 key questions, and that's what we use to set our view of quality and make the judgments that we make. Our current frameworks are made up of 70 pages. I'm sure you've touched them, depending which sector you're representing today, but there's an awful lot of detail across our various frameworks. 70 pages is the kind of baseline average, ratings characteristics you can see in there, and together around 335 key lines of inquiry and prompts. So I'm hoping that those numbers flag the fact that we really need to simplify these, not just for colleagues in CQC. Again, this is about making it simple, easy to understand and transparent for providers, importantly, and people who use services. So our single assessment framework will be used from the point of registration right through ongoing assessment and ultimately for the rating of our providers. As I say, this will make things clearer for everybody, reduce duplication burden, and ensure that everybody, importantly people, are really clear of how CQC is approaching its work. As we've developed our framework, we've drawn upon the previous work of Think Local Act Personal, so the TLAP work, and that's the work arising of the shared approach between National Voices and the Coalition for Collaborative Care. And I'm hoping everybody's familiar with this. We'll come on and show you some examples, so don't worry if you're not. But it's all about making it real. Importantly, the making it real approach sets out what good and outstanding person-centred care looks like for people using services. I'll come back to that one a little bit later. Much of the assessment framework will feel very familiar. We're not reinventing the wheel in what we look at, but it needs to be delivered differently. It needs to be applied differently, and the process for how we apply the framework will feel different. So another example. You'll be familiar with us talking about monitoring, inspecting, rating as different steps. We see them as distinct elements of the model currently, and we inspect at a set point in time based mainly, as you'll all know, on a previous rating. In the future, we're moving away from that approach. We don't want to be separating and singling out what we know through monitor, inspect and rate. Instead, we want to use all of the information that we receive, collect and analyse to assess providers more frequently without, and importantly here, being set to tied days. It's all about the insight. What is it telling us? What's proportionate and what and when is the right action? So that information will come from multiple sources and be gathered in a variety of ways. Our operational colleagues, that's teams you might currently think to as our inspectors, they will continue to play a key role in increasing the flow of information into our future regulatory platform. There will be a really dynamic process, and CQC colleagues will have a clear and accessible dashboard through that regulatory platform, helping us to make better, timely, proportionate decisions. Our colleagues will have greater ability to identify the best course of action. So it's really targeted, it's really appropriate to what the data is telling us. And it could be that they're working in a local area even to find out more information or schedule a particular site visit to a service, observe care, speak to staff, etc. There's lots of different ways that we will be out and about crossing thresholds. It's important to note that in services where there's a higher likelihood of a close culture developing, that we will be prioritising those services for the site visits. More flexibility and improved prioritisation across all services means that we can focus our activity where it's most needed. Right, so next be categorising and scoring evidence. So at the moment we make judgments against the ratings characteristics. Then our key questions ratings aggregate, particularly thinking here there's lots of reps from NHS Trust, isn't there? So we do lots of aggregation, bringing those ratings, bringing locations together to give us an overall rating. In the future we want to be more consistent and transparent in our approach there, including how we make those judgments on quality. We want our ratings to better reflect the care that people are receiving and be clearer about provider or services in terms of how they sit within the bands of those ratings. And to address this, we're developing a way to categorise and score our evidence as part of those assessments. In terms of reporting and the outputs of our assessments, at the moment, you will all be familiar, we have long PDF reports. They're not accessible, They take an enormous amount of time for us to write and indeed for the public to read. So in the future, we want to move away from those long PDFs. We know they don't work for the public, and importantly for you as providers, then they're inaccessible and they're not fit for what people are expecting from us. So we'll be able to give a much more up-to-date view of quality through this entire new model. We can't do that unless we streamline the way we work, including how we publish reports. So they need to be shorter, more tailored to the audience, and we want people to be able to read them in a really accessible way, so that ultimately people can make choices, better choices about their care as the information is presented more clearly for them. The last point here is that our benchmarking through the regulatory platform, through the data and insight that we will hold, means we'll be able to help providers improve using the functionality of the provider portal rather than publishing that online. So more to come on that one. Now, if we could move the slide on, colleagues. Thank you. Okay, so I've talked a little bit about the single assessment framework. So this is about what that looks like. So a bit more detail here. As I say, it's built on our 5 key questions and our well-known ratings scoring system. It's what we use to set out our view of quality and make our judgments. I mentioned before that we've drawn on the work done previously by Think Local, Act Personal, National Voices and the Coalition for Collaborative Care, making it real. They co-produced a personalised care and support framework, and we're using it. It can be used really well by people who work in adult social care, health, housing, and indeed people who use services, because it sets out what good and outstanding person-centred care looks like and what people should expect from providers, commissioners, and importantly, system leaders. So the Think Local, Act Personal, the Making It Real, it focuses around I statements, we statements as the starting point, and that's how we're using them through our assessment framework, taking the important step for us, therefore, towards truly regulating through the eyes of the public using services. As the statements encapsulate the views and expectations of real people, we feel that we're giving them a really prominent place then in our single assessment framework, focusing on the whole health and social care system and how it's working together to meet the needs for people. So a really human and relatable approach here. Okay, so in terms of the ratings, we've confirmed that our ratings and the 5 key questions will stay central to our approach, but we're introducing, to get there, a set of quality statements. The quality statements will be pitched at the level of good and linked to the regulations that will ultimately help us make judgments on the quality of care. The quality statements will replace our key lines of inquiry, CLOEs, and indeed the prompts that support those CLOEs. And the quality statements will be expressed as the we statements in terms of making it real. So we will have I statements on behalf of the public, people who are using services, and we statements for providers and leaders. So it should be really clear for providers about our expectations on them, while also reducing the duplication that currently exists across our CLOEs. When we move to the next slide, but not quite yet, Steph, we've got some examples on those I and we statements, so hold that thought. But we'll use the full set of statements in our assessments, all sectors, all service types and at all levels, using them, as I say, to register services with provisional ratings of good, right through our work for ongoing assessment and indeed our new work looking at local authorities and integrated care systems. There's another slide coming on that one in just a moment's time. So we want to be more consistent, I hope you're hearing that, and transparent in our approach, how we make judgments on quality. To address this, we're developing a way to categorise and score evidence as part of our assessments. The evidence categories will bring more structure, more transparency and more clarity in our process for assessing quality. Those 6 categories, you can see them there, are people's experiences, feedback from staff and leaders, observations of care, feedback from partners, processes, and indeed, importantly, outcomes of care. So to enable us to be clearer with providers and the public about how we use the information we have, we will set out what evidence will be required for each service type and each level, including registration. In many ways, this will be the data and evidence already familiar to you as providers and to our inspectors, but by bringing those 6 categories together and setting what we always need to collect to make a decision alongside the way of scoring evidence, we'll be able to bring a more structured and consistent framework for assessing quality. So in summary, we've said a lot there, we've covered a lot there, I'm looking forward to discussion, but in summary, our single assessment framework will act as the golden thread, right from initially registering a service at the level of good through to that ongoing and ever continuing assessment of quality. Okay, if we move on to the next slide, this is our, some examples on the statement. So we've got the I statement, the people, the person view, and the we statement, which will always be the provider or indeed the system leadership view. So I'll give you a minute to read those yourselves. These are clearly around effective care planning. Okay, so you can see how the bar is set there through the use of those quality statements, perspective of people through I, and providers and systems through we. So we're looking forward to introducing our quality statements. Next slide, please. Okay, I've touched on this briefly through some of the previous slides, but a bit more here around our oversight of systems and some of the ambitions in our shaping up of approaches. As I say, we're developing our single assessment framework so it can be applied flexibly to meet different requirements, and that means it's about meeting requirements at provider level, social care, health, but equally and importantly it can be applied for local authorities and integrated care systems. So a little bit more on those. So for ICSs, integrated care systems, we could assess, we're still working through this, but we're likely to assess across the following themes: leadership, integration, quality and safety. For leadership, it'll be about how well system leaders, i.e. The Integrated Care Board, the Integrated Care Partnership, the local authorities, for example, are aware of the areas for improvement throughout and across the integrated care system, and how they're setting strategic direction to improve through effective integrated care strategies and joint strategic needs assessments. We'll be looking at how well system leaders are working together as an equal partnership to undertake shared planning and make decisions together. And we'll be looking at how effectively decision making and responsibility is being delegated to place. And indeed, importantly, how this is improving outcome at those more local areas. We'll be looking at how well system leaders are working to share learning, best practice, and that might be at regional, national level. And we'll be looking at system leadership in terms of the identification of and how the system is addressing health inequalities in their area. For integration, it's about how integrated patient pathways are and whether population needs are being identified and met through the joint planning, and how effectively system leaders and partners are using integration tools, for example, the Better Care Fund. And lastly here, how well information technology is being used as a tool for integration. For quality and safety, it will be about how well system leaders are dealing with any quality and safety issues highlighted as part of a provider inspection. So we know that there's other regulatory bodies we do need to flag here, specifically NHS England and Improvement, of course, who have oversight responsibilities for ICSs. So I do want to flag loudly, we're all working together to make sure we're aligned and reducing burden duplication. And then, so what about our approach for local authority assurance and the assessments that we're thinking to in that space? It will all be around how and what approaches look like to work with people. So that's around assessing people's needs, supporting people to live healthier lives through prevention, and thinking about well-being, sharing information and advice early. Again, it will be around how support is provided, specifically via integrated ways of working and with partners across the wider area. We'll be thinking about ensuring safety So safeguarding, safe systems, continuity of care. And again, we'll be thinking about leadership. So it's governance, learning, improvement, innovation. Each of these themes, to flag again, each of these themes will have several quality statements, I statements, for example, within them. So choice, control, personalisation are threaded through our entire framework and approach. Is always around what is a local authority, what is a system, what is a place doing to understand the needs of its population and plan accordingly to meet those. Okay, next slide, I think, is about what next. Yeah. So there's lots of ambitions in there. Again, I'm looking forward to the discussion. So for us to deliver this, the wider ambitions of our strategy, our new regulatory model, we need to organise ourselves differently. So what does that mean? We're exploring how our internal colleagues can work in multidisciplinary teams in the future. At the moment, you will know our teams work either in hospitals directorate, the adult social care directorate, or indeed the primary medical services and integrated care directorate. But we see multidisciplinary teams working more flexibly, drawing on the variety of expertise that the team brings together, forming a view of quality of care in an area so that ultimately they can respond more quickly to high risk issues, explore complex services together and think about that whole system working. We will continue our engagement, so events such as these, and we will start to scenario test, importantly, thinking to the regulatory model with providers. We'll continue to share opportunities of where you can support us when those opportunities arise, and we'll keep you informed of the details in terms of any rollout, so any final planning to introduce our new model. So that's it in terms of next steps. Next slide. Yeah, okay, I'm really looking forward to getting to thoughts, queries and steer from you. But before we do, of course, here is how to stay up to date. So you can get involved on our digital platform. That is our Citizen Lab area. And on there you can share your expertise, experience, thoughts, contribute to discussions. Indeed, sometimes it's about reviewing documents, taking part in a poll or survey, or contributing on an idea board. There's loads on our Citizen Lab. Please do access if you haven't already. There's our provider bulletin and our blogs. You can sign up to receive those if you're not signed up already. Lots of more detailed information about the sector, and it's straight into your inbox, so no effort required once you've signed up. CQC's Twitter account, obviously the source of our most immediate information, and lastly CQC Connect, where you can listen to the latest episodes in terms of our podcasts and sharing information through the Connect platform. So that's it for how to stay up to date.